Hello everyone, good evening, welcome to today's class. Just give me a few seconds to get started. I hope you guys can see me and hear me clearly. Yeah, just getting started, just give me a second. Great, okay. Alright, so hope you guys can see me and hear me clearly. For anything you can always write in the chat box so I can see your messages. Hello everyone, hi. Right, so we are online. So from this week I am beginning a Superspeciality series every day 6:30 p.m. Today is going to be part 1. We will cover all the important Superspeciality topics in surgery. Today we will be covering mainly plastic surgery and wounds. No doubt that is extremely important. We'll try to solve as much as possible today. As people are joining in, let me tell you a little bit about myself and our classes. I am Dr. Amrit Nasta, teaching on the Unacademy platform, and I am your surgery educator. I am a bariatric surgeon from Mumbai. If you wish to learn more from me, please download the Unacademy learning app. You can follow my profile, you will get all the updates about my upcoming classes, as well as you can follow the profiles of all the other educators covering all 19 subjects, which will help you prepare for your NEET PG, FMG, INICET, whatever exams you are targeting. So we have a plus platform, we have an iconic platform, which all have their own benefits, which I will just tell you a little bit about. Uh, if you wish to subscribe, remember to use this referral code, that is 10 surgery. This code will get you a 10% discount in whatever subscription plan you choose. A lot of batch courses have just started for different exams. Whichever exam you are targeting, you should subscribe accordingly. So if you take the plus subscription, you get live classes, quizzes, batch courses, and so on. Like a lot of batch courses which have just started. If you take the iconic subscription, you get two benefits. You get benefits of plus as well as prep ladder. The prep ladder gives you recorded lectures, it gives you handwritten notes, so it's of course a little bit more. It's all up to you, depends on what exam you are targeting. Whether you are targeting something next year, then take a longer subscription plan. Remember to use this code 10 surgery. If you are preparing for some exam this year, maybe NEET PG in April or INICET or FMG, you take a shorter subscription plan but use this code 10 surgery. This code will get you a 10% discount, as you can see, in whatever subscription plan you choose. Okay, so that is about us, that is about our platform. Good evening Datesh, Dr. Kostov, great to see you guys. Right, so let's begin today's class and let's see how many MCQs you can solve, how much you have learned attending my classes recently, and how do you handle these kind of questions. Okay, let's see if you've ever seen this device. I gave a clue in the start. Let's see if you've ever seen this device. This is a new question. This has never been asked. And this picture is there in Bailey. So I've taken the picture, not the same one, sort of from Bailey. You see, this looks like some sort of bag or a pouch. There is a tube over here and there is something unique over here. What is this device? Is it a JP drain, Thromowag drain, tissue expander, or chemo port? Each of these have something unique in them, unique to identify. And these are the kind of image-based questions that we have to be able to answer. That says tissue expander. A bag like this, with a tube like this, and something over here. This looks like the stethoscope, the bell of the stethoscope. So what is this? Anybody else? Yeah, that says tissue expander. What is a Jackson plant drain? Any idea? And what is a Rhomboid drain? What are these two drains? They come in the same group. Varun says Rhomboid. Very good. Varun was there for my orthopedic class also. Siddharth also says Rhomboid. So this is a Rhomboid. Rhomboid is a suction drain. Okay. Alright, fine. Excellent. Unfortunately, you guys are wrong. Datesh is right. This is a tissue expander. Before I go to tissue expander, let me tell you what is a JP drain. JP drain looks like this. There is an egg-like thing. It's a bag. It has a tube. Yeah, it has a tube, absolutely right. And at the end, it has something which is white in color with perforations in it. Okay, it with perforations in it. And this egg-like thing gives you the negative suction. It gives you the negative suction. Similarly, the Rhomboid drain is quite similar. The Rhomboid drain, it's a bag, again it's a collecting bag like this, but it is cylindrical like this, so it can be compressed. This also has a negative suction. None of these look like that. Even if you didn't know whether it's JP or Rhomboid, even if you didn't know this, tissue expander has something very unique. You know what this is? This is unique to a tissue expander. It is also seen in a chemo port, but it is unique to a tissue expander. What is this? Any idea what this is? Yeah? Any idea what this is called? So this is the adjustment port or the adjustment tube. Now let me tell you what is a tissue expander. It is used by plastic surgeons. I'll show you how it is used. What is a tissue expander? Now understand, let's say the skin in this area is very tight. Okay, the skin in this area is very tight, burns contracture. And I want the skin to be expanded. This will only expand, this tissue expander will only expand skin and subcute. It's not going to expand anything else. It's a tissue expander of skin and subcute. So what is done? This bag that I showed you is placed subcutaneously. And when it is placed, it is deflated. So it's flat and it is placed in the subcutaneous plane with the tube and the adjustment port next to it. Everything is subcute. First like this, this is the bag, this is the tubing, subcute, and this is the adjustment port. Everything is buried under the skin. Now periodically, whenever I want, I fill some saline through this adjustment port and expand the bag over a period of time. Like I'll tell the patient, come every week and I put 5 ml, 10 ml, 15 ml, as much as the skin can take. Gradually, as the expander becomes bigger, the skin on top starts hypertrophying. Okay, the skin undergoes an increase in dimensions. It's actually expansion without hypertrophy. Size nahi badhegi. Maybe the number of cells increase or the cells get stretched. So I have an excess amount of skin. Then I remove the expander, so it is a surgery. I remove the expander and now I am left with a lot of extra skin which can be used for reconstruction. Good evening, Seni. Which can be used for reconstruction. So this is a tissue expander. It is nothing but a balloon and it has a subcutaneous adjustment port. This is what you need to know about it. And have a good look at this image. It has never been asked. It is a pure plastic surgery thing and it is there in Bailey, so we need to know about it. It will give me growth of the skin, so I'll have excess skin which I can use for reconstruction. So if there is some area nearby which has to be reconstructed, I can use that skin flap. Fine. Jackson Pratt and Rhomboid both are negative suction drains. इसमें कोई suction नहीं है. ये तो fill होती है. This is not a drain. This is a bag. Okay. Are we good with this? So this is about tissue expanders and implants. Alright. This again image I have taken, father of modern surgeologist. Okay, I don't know what that means. What type of flap is shown in this image for reconstruction? Identify the type of flap shown for reconstruction. I will tell you what is happening here. The defect is in the lower eyelid. I use a part of upper eyelid, pull it down and cover the defect, as you can see. So upper eyelid is used to reconstruct the lower eyelid. What type of flap is this? I told you today's class is based on plastic surgery and burns. So I'm starting with plastic surgery. Then I'll move on to burns. So what type of flap is this? Advancement flap, rotation flap, bucket handle flap or bilobe flap? Absolutely must know. Very good. Shreya, Mahesh, Kaustuba are saying A, Datesh is saying C. So is it an advancement flap, rotation, bucket handle or payload? Okay, I'll tell you what is happening here. Upper there is a flap which I'm taking, which I'm shifting down to reconstruct something lower down. My pedicled, no, it's not a pedicled flap, it's a local flap. Pedicled flaps are distant flaps. This is local, na? It's all around the eye. It's not a pedicled flap, it's a local flap. Right? So this type of flap where the upper eyelid has been put to the lower side to reconstruct the lower lid is called bucket handle. You can see it's going down like a handle of a bucket. This is a bucket handle flap. It's not an advancement flap. Advancement flap is entirely continuous. It is entirely continuous. Okay, so this is a bucket handle flap used for lid reconstructions. Understand what are flaps. Since you mentioned pedicle flaps, what is the meaning of the word flap? Flap का मतलब क्या होता है? Anybody? What is a flap? And how is it different from a graft? Yeah, what is a flap and what is a graft? There are two terminologies in reconstruction. One is called graft, one is called flap. Skin and muscle is a flap. And what is a graft? Only skin. You know there are skin flaps also. Myocutaneous flaps, osteocutaneous flaps, cutaneous flaps. So this cutaneous flap is also a flap. Very good. Graft has no blood supply. Flap carries its own blood supply. It carries its own blood supply. Okay, so wherever it goes, it gets the blood supply from the host or it requires vascular anastomosis. And this has no blood supply. So that is graft. Graft, skin grafts. STSG, FTSG. A flap is basically of two types. There is a local flap and there is a distant flap. All of these are types of local flaps. A distant flap is a flap where the reconstruction is away from the donor side. It is quite away from the donor side. There should be some normal tissue in between. Distant flaps are of two types. One which is called a pedicle flap and one which is called a free flap. So there are two types of distant flaps. So you were saying bipedicle. Pedicle is a distant flap. All these are local flaps. Now coming to local flaps. They are used in the vicinity. You may take the skin, you may take subacute, skin, subacute muscle, skin, subacute muscle bone, skin, subacute fascia. All those types of flaps are possible. But only skin can also be taken. Anybody, any example of a pure cutaneous flap? Any idea? Anybody? Since you mentioned purely cutaneous, only skin and little subacute is taken. Yeah, only skin and subacute is taken. Suturing कब पढ़ा रहे हो? Suturing मैंने पढ़ा दी है. Mahesh, you have to come on my Telegram group. Only then you will know. If you will just ask in every class, you will never know. Varun is saying SSG, split skin graft. No, I'm talking about cutaneous flap, not graft. Cutaneous flap. Skin graft is a graft. It doesn't have its own blood supply. Yeah. What is a cutaneous flap? Any idea? Any example of a pure cutaneous flap? Yeah, starts with a D. Abbey Aslander, no, this is Abbey Aslander, it's not pure cutaneous. It's a skin with subacute, with mucosa. उसमें तो mucosa भी आती है. Okay. It starts with a D. I've given you a clue. Think about it. Okay, if you can't get the answer till the end of the class, I'll give you the answer. Okay, so these are some commonly performed local flaps. Let's say there is a defect over here. Breast construction flap inferior epigastric. No, those are myocutaneous. Okay, those are myocutaneous or they are cutaneous with some amount of subacute. They need bulk. If you are reconstructing the breast, you need bulk. Absolutely right. Deltopectoral. Deltopectoral is considered a cutaneous flap. उसमें deltoid muscle नहीं लेते. So DP flap, deltopectoral. used for oral reconstruction. It's a cutaneous flap. There is no deltoid muscle which is harvested in that. Okay, now let's say there is a defect here. I take tissue next to it like this, cut it, shift it or switch it or rotate it and put it over here and then suture. This type of a flap commonly used is the rhomboid flap. You can see the shape of the flap is rhomboid. Commonly used for pilonidal sinus reconstruction, where it is called Limburg flap. If I use it for pilonidal sinus reconstruction, it is called Limburg flap. This is for lip reconstruction. Let's say a person had a malignancy in the upper lip, so resection was done in the upper lip, then the lower lip, a part was taken. It was not disconnected, it was taken, rotated on the upper lip and fixed to the upper lip. What is this? What is the name of this flap? Abbey Aslander, Abbey or Aslander, or all are the same? What type of lip reconstruction is this? Abbey at Aslander or Aslander? I have discussed this in one of my earlier classes. So this is the Abbey flap, where I am reconstructing the central part of the lips. It's called the Abbey flap. The same flap, the defect was at the angle, and I used lower lip, rotated it, put it in the upper lip. If I do it at the angle, it is called Aslander. Okay, so Abbey is for central, Aslander is for reconstruction of angle. What is the basic difference between Abbey and Aslander? Central है तो Abbey, lateral है तो Aslander. What sense does that make? How are they different? Principally they are the same. Lower lip upper lip पे लगाऊंगा या upper lip को lower lip पे लगाऊंगा, कर रहा तो वही हूँ. Lip is being transferred from up to down or down to up. Why in the central part it's Abbey? Why in the lateral part it is Aslander? Is there any difference? Because someone earlier, Kostov only earlier said Abbey Aslander. Is there any difference between Abbey and Aslander, or they are the same? Because if you read in many books also, they are taken as one. Abbey Aslander flap for lip reconstruction. Is it so? Yeah, any idea? Anybody? Different vessels? No, not really. They are not based on fixed vessels. They are not based on fixed vessels. It's based on vicinity, na? Not much difference in the vessels. They will be branches of labial arteries. Vessel to hai labial artery. So the difference is, understand, in the central part, when I do this switch, when I do this transfer like this, the lower goes to the upper, there is a connecting bridge. The mouth will not open. Okay, the mouth will not open. There is a connecting bridge. So in the Abbey flap, I have to do a second surgery where I disconnect it. So Abbey flap is two-staged. It is two-staged. Aslander on the other hand, because it's at the angle of the mouth, rest of the mouth will open. Aslander flap is usually going to be single stage. Okay, it's going to be single stage. That's why they are taken differently, conventionally, but they can be considered as one as lip reconstructions only. But this is the basic difference between the two, which you need to know. This you will not find in books. You had to read a lot online to get the difference between the two. I myself didn't know till a few years back. Okay, extremely important. Extremely important. What are these things that you see on the face representative of? This image also is in Bailey image. Plastic surgery in Bailey is such a small chapter, and there is such a mountain of information, basic level information, that we must know. What are these lines representative of? Dermatomes, plascolines, lines of skin tension, or myotomes? Okay, so I got 2-3 answers. I got dermatomes, I got plascolines, I got skin tension or Langer's lines. Very good, excellent. different answers. Okay, these lines need to notice two things. They are on the face and they are going all across the face, and they are more or less horizontal. More or less horizontal. More or less horizontal. Okay, these are lines of skin tension. They are also called as Langer's lines. Okay, they are also called as Langer's lines. Dermatomes are much bigger. Okay, dermatomes are much bigger. They won't look so small uniform. What are Blaschko lines? What do they represent? This was asked when I gave entrance exam. तभी NEET नहीं था. That time it was called AIPG, All India Postgraduate Entrance, AIPG. That time they had asked Blaschko lines. तभी image based questions नहीं आते थे. There was no imaging. Everything was, there was no online exam. The exam was, they used to give us a question paper sheet and an answer paper in which we had to, it was an OMR sheet. You may have heard of it. So there is, say, question number 31. Then there is A, B, C, D. ऐसे होता था. With, ऐसे circle used to be there. And if I want to mark C, I have to darken the circle like this. So tedious. By chance 31 का आंसर 32 में मार दिया तो दो आंसर्स रॉन्ग हो जाते थे. Such a disaster. You can't change the answer. Once you marked, it's marked. End of the story. You are lucky it's online. You can change the answer. हमारे टाइम पे ऐसे होता था. OMR sheet. So that time they had asked Blaschko lines. मुझे नहीं मालूम था. When I gave the exam, I did not know what were Blaschko lines. Anyways, these are lines of skin tension. They are called as Langer's lines. Langer's lines represent arrangement of dermal collagen. Arrangement of dermal collagen. What does this mean? It means on the face, probably the collagen fibers would be arranged like this. Probably. Which means if I take an incision along the Langer's lines like this, the healing will be appropriate. Good healing. Okay. Scar will be good. These are Langer's lines or lines of skin tension. So skin tension, good healing, because that is going to be the arrangement of dermal collagen. So I'll show you. Look at this image. Whatever incision I want to plan on the body, ideally it should be along lines of Langer. Because if I take incisions along lines of Langer, like let's say in the lower abdomen, if I take oblique incisions, appendicectomy, very good healing. Upper abdomen, ideally horizontal incisions. We never do take, but ideally you should take horizontal incisions. These will give best skin healing. Best skin healing, so best cosmetic outcome. They are going to give a cosmetic scarring. These I am sure you can make out. These are dermatomes. Dermatomes are based on neurological or nerve innervation. Right, like a particular area will be receiving dermatomes of a particular spinal cord segment. ये तो easy है. This is all neurology. These I want you to focus because this image has never been asked. ये image कभी नहीं पूछी है. Okay, और ये image books में भी नहीं है. These are Blaschko lines. Now I'll tell you how do you identify Blaschko lines. Look at the trunk. First of all, they are not horizontal. Langer's lines are mainly horizontal because dermal collagen is mainly horizontal. These are vertical. They look like stripes of an animal. If you see carefully, this person looks like a zebra. These are stripes of a zebra. And they don't cross midline. At least in the trunk, you can make out they don't cross midline. These are your Blaschko lines. These lines represent skin development. Okay, they represent skin development. When the skin develops, the skin cells are oriented along the Blaschko lines. So you may have learned this in dermatology. Blaschko lines for skin development. A lot of skin diseases are along the Blaschko lines, like lichen planus or any other skin disease you must have heard, which is along the Blaschko lines, lichen planus, some sort of nevi, some sort of pigmentary disorders, they are along the lines. These are lines of skin development, they never cross the midline. These lines are evident in other animals. So animals which have stripes are nothing but blascolines. They are representative of blascolines. These are lines of skin development. Okay, please have a good look at this image. I got this online. Never been asked. But blascolines was asked. It was asked in the exam that I gave. I didn't know. Now you know. You cannot make a mistake. Okay, Langer they have asked. So Langer they won't ask again. Okay. Important question. What percentage of total burn surface area leads to shock and circulatory collapse? This is percentage total body surface area of burns or total burn surface area. Can lead to shock and circulatory collapse. Means how much should be a percentage of burns? You know there are a lot of ways of calculating this. There is a rule of Wallace rule of 9. Then there are some charts. You got to tell me the names. Whose charts are they? Then something based on palm. So there are a lot of ways of identifying what is the burn surface area. When I get this number, let's say the person has a total burn surface area of, for example, 30%. Is he at risk of shock? Or when it's 15%? Or when it's 40% or 50%? Dadesh, Kaustubh, Neha Kumar have said 15%. Only 15%. Varun has said 40%. Acha. Okay. And Kaustubh has given some other names also. Lund and Browder charts. Excellent. Absolutely right. Very good. Very good. Very good. Very good. Okay. Alright. So, first things first. Understand if the burn surface area is more than 15%. Just 15% in an adult. It can lead to severe hypovolemia. In a child, how much should it be? In a child? Child more than what percent? Can lead to circulatory collapse. If the burn surface area is more than how much percent? In a child, 10%. Excellent. These are the two numbers you need to remember. Please understand, it's not a very big number. 15% is nothing. 15% means if both my upper limbs are completely burnt, both upper limbs, that becomes 18%. Or if one entire lower limb is burnt, that's not much. But even this much of burns can lead to circulatory collapse. Now, how can burns lead to circulatory collapse? What does this mean? Please understand, when you get burns is like a trauma to the body. It's like a trauma to the body. Obviously, there is going to be skin loss. The barrier is lost. Two effects happen due to this trauma. One is the skin loses the barrier function. So the skin barrier is gone. The second thing, which is more important, that's why I put it as number 1, is your body gets an inflammatory response. What is this inflammatory response called? Your entire body gets inflamed, or your entire body mounts an inflammatory response. What is this called? What is the inflammatory response? That happens in response to burns, it happens in response to surgery, in response to trauma, mental stress. Anything can give you this inflammatory response. What is this called? Yeah, it's a 4-letter abbreviation. What is that? How when the body responds to any severe trauma like burns, it's called, yes, absolutely right, it is called SIRS. Because of this inflammatory response, your endothelium becomes leaky and you get edema. Basically, third space loss. Your fluid from intravascular compartment goes to the extravascular compartment. So when I get burns, I have two problems. Both of these contribute to hypovolemia. So even a burns as little as 15% can give you all these problems. What is the bearing of this? I'll show you later, but for now just appreciate that your body goes into SIRS with third space loss, and if the burns is more than 15%, it can lead to profound hypovolemia or circulatory collapse. Okay, profound hypovolemia and circulatory collapse. And I'm sure you know this GI effect of burns. Of course, in surgery you need to know GI effects. You get ulcers in the stomach, curling ulcers, ileus, abdominal compartment syndrome. Why does this happen? Burns में abdominal compartment syndrome क्यों होगा? What is the reason for that? How can the pressure increase? You know what is abdominal compartment syndrome? Yeah, why does this happen in burns? Curling ulcers are believed to be because of ischemia. Why do you get abdominal compartment syndrome? Yeah, anybody? Like you get third space loss, you get bowel edema. You get edema of the bowel. That is one. Other thing is, if there are burns on the abdomen, right, you can get eschar formation. Absolutely right. You can get eschar formation. So that will also reduce the compliance of the abdominal wall. But what I'm trying to say is, it's not necessary to get burns on the abdomen to get bowel edema. Zaruri nahi hai, but it contributes. So yes, abdominal compartment syndrome is seen in burns. Alright, let's move on. This is a new question. This is from Bailey. Never asked. Absolutely important. Take it in writing. This is the question which will be expected, because it is there in Bailey in one blue table. You know, Bailey gives a lot of blue boxes. In one of the blue box, this point is there. Major determinants of outcome in burns are predicted, and 3 things are given. One thing is not given, which I have added. Major determinants of outcomes in burns patient is predicted by each of these parameters except. And this question you should expect in your exam. It is there in Bailey in one of the blue boxes, जिसमें 3 चीजें दी है, 1, 2, 3. Fourth, which is not, I have added. So what is that thing which is not a major determinant? It will to some extent have an effect on the outcome, to some extent, but not overall on the prognosis of the patient. Not overall. Yeah. Anybody? Is it depth, surface area, inhalation, location? Datesh, Aisha, Sneha Kumar and Kaustubh have all gone for location. Location doesn't have a bearing. Are you sure? Location doesn't have a bearing. So if I have burns on the face, it will not affect the outcome. Aman Sharma is saying C, inhalational burns. If I have inhalational burns, it won't have a bearing on the outcome. Inhalational burns versus burns on the thorax. Others are more important. Okay, I will accept that. So you're right, it is locational burns. Alright, it is locational burns. Please understand, depth of burns, more the depth, deeper the level of burns, more the degree, we call it degree, worse the outcome. Absolutely right. Surface area 100%. I told you, even if it's more than 15% burn surface area, it will have hypovolemia. Inhalational burns, extremely important. Extremely important. Inhalational burns, poor outcome. How do you know if someone is suspected to have an inhalational burn? What are the findings of inhalational burns? Any idea? Location has effect on local healing. Okay, on local healing. It will not have an effect on overall outcome. Okay? Like if the burns is over a joint surface, there will be more of joint contractures. I mean contractures at that site. Utna. उससे ज़्यादा नहीं. Burns over face will heal faster. Some areas will heal poorer. It will not affect the outcome overall. Yeah. What are the findings that you suspect if you are suspecting inhalational burns? किसी को inhalational burns हुए, what do you expect? In which patient will you suspect inhalational burns? Inhalation means he has inhaled a lot of smoke hot smoke and its effects. Mucosal edema, वो दिखेगा थोड़ी. That is an effect. So if someone has burns over face, burns over neck, if the nasal hair are singed, singing of nasal hair, if there is change in voice, or if there is history that the person was trapped in a room when the burns event happened. These are some of the features in whom you will suspect airway burns. And these people require special care. Maybe do a prophylactic intubation. Okay, maybe do a prophylactic intubation. This is the point which they have asked many times. Criteria for admission. This I have discussed earlier. So I will not spend too much time. Criteria for admission. Now you know why it is this. Burn surface area 15% in adult, 10% in child. Because these people are at risk of hypovolemia, which I discussed earlier. Now you know why these figures. Now you will never be confused with these figures. Okay, one option in exam I'm telling you will be total burn surface area 25%. This will be one of the options. That will be the wrong answer. It is 15%. Full thickness burns of any amount. Dangerous areas of burns. Burns over palm, burns over sole, face, genitalia. These are dangerous areas. If you have burns in these areas, these patients should be admitted. High risk of complications. Dangerous patient, extremes of age, severe comorbidities. Dangerous mechanism, airway burns or inhalational burns or radiation burns or chemical burns. These people require special attention because the effect of these things is lasting. Okay, the effect of these things will be more lasting, more damaging than what meets the eye. क्योंकि radiation burns or electrocution burns, you only see site of entry, site of exit. What has happened in the body, you don't know. So these people should be observed. These are the criteria for admission. Okay, I have discussed these criteria for admission and I have matched them with criteria for admission or criteria for CT and head injury. So if you guys haven't seen my class on trauma, I have taken 3 classes on trauma. In trauma part 2, I have compared this criteria for CT in head injury and admission and burns. I have put them the same way. So you go through that class, trauma part 2, I think that was the class part 2 or part 3 in which I have compared these two. Admission and burns and CT scan and head injury. They are very similar. That's how you remember. Otherwise there are so many things to do. How do you remember? Okay, new question. Let's see if you can handle this. This I have framed today. Okay, this I have framed today. I have not asked this in any of my previous classes. This is the burns. What is the degree? Expect these kind of questions. These are the kind of questions which are expected. They'll give you a picture and they'll tell the degree. What will you say? First degree, second degree superficial, second degree deep, or third degree. I hope you know these degrees. What are these? What degree is this? Second degree deep. Second degree deep. Okay, 2 answers. Pravesh and Aman Sharma are saying second degree deep. Okay. Anyone? Any other answer? I will give some time for you to digest. I want you to digest this image because ऐसे image आने वाले आएंगे ही आएंगे. Because now there are these rumors that there are going to be 200 questions, not 300 questions. I personally don't think so. मुझे नहीं लगता. I think it is a mistake that it will be 300 or 200. I don't think. Irrespective, surgery is a clinical subject, so we will cover all clinical aspects. Kind of question I would put. C, no blisters. B, C, no boil. D, nobody for first degree? Anybody for first degree? Okay, I am very, very happy. It gives me a lot of satisfaction when I get different answers. That means the question that I have asked is a proper legitimate question. It has provoked you to think, provoked different people to think on different points. After today, you will never make a mistake. Okay, after today, never in your life will you make a mistake. I will give you still some more time to think on what the answer could be. Okay, you can keep writing in the chat box. While I tell you, easy way of differentiating degrees of burns. Easy way. You can identify from a mile away. No, sir, it's cross checked with NBE, it is 200. Then they should give less time. Why would they give 3.5 hours? Then why would they give 3.5 hours? Then they should give 3 hours. Just pehle AIMS and INI-CET used to be 200 questions, 3 hours. Why 3.5 hours? And it's only single choice, single best response. In AIMS you had multiple answers. ऐसा नहीं था कि only one will be the correct answer. अभी जो INI-CET हुई, there were multiple responses. Long question. अरे long कितना long करेंगे? How long can they make? They will go mad in framing the question. Anyways, we will see. We'll see as it comes. As the time comes. In surgery, we do long questions anyways. So, surgery, my job to cover all aspects, long questions, short questions, factual questions. Don't worry. Anyways, Ria has said A. Might be videos or GIF. Fine, so what? You have to be prepared. No problem. Maybe it's a transition from NEET to next. Maybe they'll have next in 2022 or 2023. So maybe they are transitioning. Maybe that's why. But still, we will wait for more clarity. Clarity will come. Meanwhile, we go on preparing the way we are. Now degrees. Easy way of remembering the degrees. Alright. So let's say you have first degree, which are epidermal burns, second degree superficial, second degree deep, and third degree or full thickness. Right? Easiest way. First thing you should see is the color. Color is more than enough to identify the difference. Color. What is the appearance of first degree? What is the appearance of first degree? Color. So first degree color. How does first degree burn appear? Epidermal burns. Any idea? Red, absolutely right. They are red or erythematous. Red or erythematous, and they are dry. They are red, erythematous and dry. Second degree superficial. What are they? What are second degree superficial? Yes, they are going to be pink and they are going to be moist. Why are they moist? What is the reason for this moisture? Why are they moist? They are moist because the blisters rupture. Only when the blisters will rupture, they will become moist. If the blisters are still there, you will see the blisters. Second degree deep, how do they appear? Second degree deep. Yes. How do you get second degree deep? They are going to be white. They are going to be mottled. Mottled means they will not blanch. Okay, non-blanching. They will be mottled. There will be dots. They will be white. Third degree deep or third degree or full thickness? Yeah. Full thickness burns will be what? Any idea? They will be black or charred. They will be charred. Bus. Now look at this. What is the answer? See where my arrow ended. I wanted you to see where the arrow ended. What is the answer? What do you call this? Yeah, what is the answer? D. Absolutely right. This is third degree. Black and charred. Alright. How easy was it? Was this difficult? Not at all. Black and charred. Full thickness. End of the story. Okay. There are other points like first degree and second degree superficial. Painful. Painful. No pain. No sensation at all. ठीक है. Okay. No problem. वो फोटो में देख के नहीं पता चलेगा ना. and scarring. So here they will heal without scarring in 1 week. They will heal without scarring in 3 weeks. There will be scarring, and here there will be eschar formation. I'm sure you know what is eschar. This is how you will differentiate. सब दिखाऊंगा, don't worry. प्रवेश सब दिखाऊंगा. I have all the pictures. I don't have one picture. I could not find it on the internet. But barring that, all pictures are there. Okay. What is this? This one? Classical. This is classical burns. आप लोगों को कभी घर में भी हुआ होगा. These are domestic burns. What is this? This is second degree. Superficial. Clearly moist. Probably here there was a blister which ruptured. That's why everything has become moist. Second degree superficial. What is this? This is again second degree superficial with the blister. Blister has not yet ruptured. अभी तक rupture हुआ नहीं है. What is this? What is this? This must be किसी को iron का चटका लगाओ. You know, hot iron or hot metal, little point of contact, little for a few seconds, and you get something like this. What is this? Absolutely right, first degree. You can see it is pinkish red, dry, nothing goes wrong. Fine, first degree. What is this? I'll tell you the burn is in this area. This is the area of the burn. These are the areas of burns. What burns are these? And what is this white patch in between? I'm telling you the white patch is not the burned patch. I'm just telling you. So that otherwise, because you were asking for second degree deep. Second degree deep, it's not there online. Won't find it. Because second degree deep never comes in isolation. It is always a part of a mixed burn. In isolation, either you will get first degree, second degree superficial, or full thickness. Little trauma, first degree, second degree superficial. Too much trauma, third degree. Second degree deep is always a part of mixed burns, so it's never going to be seen in isolation. Yes, absolutely right. This is sunburn. If you go to Imagica or Water Kingdom of yesteryears, you get these kind of things. Okay, so this is sunburn. You can see this is probably the line of the vest or the swimming costume where the sun did not burn. This is first degree. Right? Any problem? Ever in your life you should not have, whether you do plastic surgery or not. If somebody gets burnt, within a few hours one of these things will start happening. You can tell him, boss, this is first degree, this is second degree superficial, this will form a blister will rupture, but it will heal with minimal scarring in 3 weeks. You can give the prognosis, right? Great. Okay, let's move on. Second degree deep don't occur in isolation, so you won't get a picture of that. I myself couldn't find it. I'll try to find it and take it in the next class, but I could not find it myself. Okay, so this was when the person has gotten the burn. Now let's say there is someone in your house who gets burnt. Bad type, like a lot of hot water fell on you or something caught fire in the kitchen. So what will you do as a pre-hospital care measure? Pre-hospital care, except. So, kitchen fire, clothes caught fire, what should you do? All of these should be done except stop, drop and roll, cool the burns area with ice, elevate the limbs, sit upright, perform both primary and secondary survey. This you who are a doctor, which of these are you supposed to do? Which of these you need not do? This is a very practical scenario. If you are saying there will be 200 questions, they will be these kind of questions. Practical scenarios. Okay, I got B, I got C. Anybody for D? Nobody for D? I'm sure you guys love trauma. You don't want to go for D. Both primary and secondary survey in pre-hospital care. And what is the stop, drop and roll? इसका क्या मतलब हुआ? Stop, drop and roll. Okay. Most of you have said elevate the limbs and sit upright. This you will not do, is what you are saying. You won't do. है ना? Okay. We will dissect each point. Then you will realize how wrong your thinking was. Stop, drop and roll simply means break the contact. It means break the contact. Right? If the clothes have caught fire, you ask him to roll. जो पिक्चरों में दिखाते हैं, they roll on the floor till it gets extinguished. Break contact or extinguish. अभी घर में तो fire extinguisher नहीं होगा ना. This is one way of extinguishing the fire. Or you put a blanket and break the fire. First thing is break contact. If it's something hot, take it away. If there is an electrocution, break the electrocution contact. All different ways of getting burns at home or in an industry. I am restricting to home because you can imagine. Cool the burns area with ice. Now understand, if I have a lot of burns on my torso, my t-shirt caught fire, I got burns on my chest, on my abdomen, on my back, on my shoulders. And if I apply the burns area, I apply ice to it. What will happen? What will happen? Anyways, the skin barrier is gone. ऊपर से I am applying ice. What will happen? ये point ना घुमा फिरा के बहुत बार पूछिए. So I was surprised you guys got stuck. If I apply ice to this burns area, what will happen? Yeah. सोचो छाती पे, पेट पे, पीठ, कमर, everywhere I am applying ice, I will get hypothermia. So please don't apply ice. What should you apply? What should you apply? Tadesh, Pravesh, Aisha, Nikhil, a very interactive class today. I am very happy. I think the 200 MCQ news has scared you guys a little bit. So yeah, need to work hard. What should you apply? You should apply cool or tap water of temperature 18 to 24 degrees. Okay, even for small burn, tap water. You don't have to apply ice. Ice is not going to make things better. Okay, cool water or tap water. So this is the incorrect answer. Elevate the limbs, sit upright. Of course, sitting upright will reduce the risk of aspiration. It will improve his airway. If he has inhalational burns, elevate the limbs will improve his venous return. I'm sure you know this is all medicine. Venous return, cardiac output. Anyways, you expect him to become hypovolemic. So when he is being taken to the hospital, he should be upright, preferably upright, and not supine, preferably. And you may perform both primary and secondary survey. May perform if the situation demands. Okay, all these points I discussed. When do I suspect airway injury? This also I just discussed a few minutes back. Okay, easy question. Which of these dressings used in burns is associated with metabolic acidosis? This is there in Bailey. Bailey question. What does Bernol does? Bernol and all are antiseptics. They will reduce the risk of infection. They will not promote healing. If I am correct, Bernol is an antiseptic. I think it contains mupirocin or some ointment or silver sulfadiazine. I don't know what it contains. But all these ointments are antiseptic ointments. Okay, so I got A and C. It's a very simple way to get to the answer. Metabolic acidosis. If you want acidosis, you require acid. So it will be from acetate. Answer is mafenide acetate. Okay, acidosis, acetate. और कहीं acid तो नहीं लग रहा मुझे. Important points about some of them. SSD. This is the most commonly used ointment. Most commonly used. In my residency, we used to use. It used to come in a big black box, very big box, because you have to apply over a large area, a white color cream. Okay. Most commonly used. It has anti-pseudomonas effect. Anti-pseudomonas effect. Silver nitrate also has anti-pseudomonas effect, but the problem is silver nitrate causes black staining. Okay, it will cause black staining. So if I put any cloth on this patient or the blanket will get stained black. The mattress will get stained black. The furniture will get black. भर के लगाते हैं या भर के लगाते हैं. So everything gets stained black. The blanket, the mattress, the bed sheets, the furniture. Everything gets stained black. That's why it's not used. Otherwise, activity wise, silver, anti-pseudomonas. What is the advantage of cerium nitrate? Anybody? Unique about cerium nitrate? Yeah, any idea? What is unique to cerium nitrate? It has some unique benefit. It is a painful ointment to apply, expensive, but it has some benefit which the others don't. Any idea? It penetrates eschar. Okay, it improves local immunity. Improves local cell mediated immunity. ये भी MCQ है, ये भी पूछ सकते हैं. In what percentage, in what degree of burns, what should be the degree of burns beyond which I should apply these things? Do I apply it for first degree, second degree superficial, second degree deep, or third degree? For which of these burns thickness do I apply these? Or they are applied for all burns? Epidermal होए, superficial, partial thickness, full thickness, सारे में लगाना है. कितने में लगाना है? Do I apply all the silver sulfadizine भर के on all the burns patients, or only when there is a certain degree of depth? Very good, absolutely right. So they are applied for second degree deep and third degree burns. तो ये जो थोड़े superficial है उनमें क्या लगाऊं? Yeah, second degree deep and third degree. What about the lesser degree of burns? What do I apply there? उसमें क्या कुछ लगाना ही नहीं है क्या? ऐसे ही खुला छोड़ दो? Or I apply something? Yeah, any idea? What do I apply for lesser thickness of burns? Real world scenarios: paraffin, Vaseline. Okay. Aloe vera. Don't apply aloe vera. Burnol. Oh, Burnol is your favorite. You're promoting it. Paraffin. Okay, I'll tell you what you're supposed to do. You are supposed to apply dry dressings. Dry dressings, because understand, these wounds will keep seeping liquid. You want the whatever is getting exuded to be absorbed, so you need a dry dressing. But the problem is when I apply the dressing, let's say I apply gauze piece or cotton, right? When I remove it, it will tear. It will hurt the patient. So I apply dye dressing with something like Vaseline. Something that will allow the dressing to form a coating, so when I remove it, it becomes painless. So I apply like what you guys were saying, Vaseline or paraffin or Sofra tool, those kind of things. That is the intent. So Vaseline impregnated gauze. Okay, antibacterials, deep partial thickness or full thickness only. There is something called as hydrocolloid dressing. This is used for mixed depth burns. Okay, this is used for mixed depth burns. Partly full thickness, partial thickness, mixed depth, hydrocolloid dressing. Okay, hydro means and colloid means again this dressing will absorb the exudate. It will absorb the exudate. Hydro means water. Colloid is something that pulls the water. This pulls the water. You know colloids. They are plasma expanders. They pull the fluid. Hydrocolloid will pull the water from the burns wound and absorb it, so the wound will heal faster. Right? Okay. Let's see if you have seen this. Following abdominal trauma. This is actually a plastic surgery question. It's not a burns question. It's not burns. Burns we are done. Plastic surgery question. After laparotomy, abdomen could not be closed, probably because of bowel edema. If you can't close the wound, you have to leave it open, but then the bowel gets exposed. So you cover the exposed bowel with this. What is this? With which you are covering the bowel? Bogota bag, mesh, laparostomy, tension suturing, or vac dressing. Okay, so what is this? What is this made from? Any idea? ये बनता कहाँ से? You see these lines across it. Yeah, absolutely right. It's called Bogota bag. Other name for Bogota bag? Other name? अदर नेम, अगर मैं बोगोटा बैग की जगह कुछ और भी नाम दे सकता हूँ. That name that I'm going to give you is usually used to cover children, neonates who have that what is that called, exomphalus. Exomphalus, maybe the bowel is exposed, right? So that is used to cover the exposed bowel. What is that called, where you keep the exposed exomphalus in with the cover? It's the other name for Bogota bag. They are not really the same, but principally they are the same. It's called what? It's called a silo. Okay, remember these names, Bogota bag or silo. ये जो yeah, silo closure bag, absolutely right. This can be made from any sterile bag. Usually we use urine bag. जो urine bag होती है ना, from the urine bag we cut it. It has to be sterile. You cut it in the circular shape, a sterile urine bag, and you fix it to the wound. So you can use a sterile urine bag. It's called a Eurosac bag, not a bag which has urine, without using it before. You take that bag, you cut it in the shape of the abdominal wound, and you stitch it. This is called Bogota bag. Sometimes you can use a mesh directly, exposed mesh, but mind you, this mesh cannot be a Prolene mesh. You cannot use a Prolene mesh on the bowel. Ideally, this should be a biological mesh. Ideally, but you don't get biological meshes. That's why mesh laparostomy is not very commonly done. This is better. What is this? What do you see in the third image? What is this? Some nice sponge looking thing with a tube attached to it. What is this thing? Any idea? Ever seen this? It's a sponge with a plastic on it with a tube coming through it. This will be connected to some machine. यहाँ पे ऐसे machine जाएगी जिसपे वो attached होगा. And the machine has a, yeah, the machine has a pressure -125. So this is a VAC dressing. You know what VAC stands for? Vacuum assisted closure. Vacuum assisted closure device. So this is a VAC dressing. Yes sir, देखा है, याद नहीं आ रहा. अच्छा, okay. All right. Let's see if you have seen this. Identify the incorrect statement. Hypertrophic scars are due to prolonged inflammatory phase of wound healing. Hypertrophic scars are seen along lines of tension. Keloids usually occur on hypopigmented skin. Hypertrophic scars improve with time. ये देखा है कि नहीं? This is again pure plastic surgery. And again, this is sort of a new question. Part of it has been asked, part of it I have put newly. Yes. What does Datesh and Kaustubh and Vishaka say about this? And Sharma and Varun? Yeah? Kaustubh says C. Oh. You know the phases of wound healing? I hope you know the phases of wound healing. Anybody can tell me phases of wound healing? Important. What is the first phase of wound healing? Phase of something, something, something. What are these phases? While you think on the answer. Okay. Fine. You type this while I'll discuss this. Hypertrophic scars are due to prolonged inflammatory phase. Yeah, absolutely right. This is correct. That's right, Kaustubh. So the first phase is phase of inflammation. Second is phase of proliferation. And third is phase of neovascularization or remodeling. I had discussed this in context, if you remember, of fracture healing also, in context, correct? Inflammatory phase is where you have the PDGF and all those things. There is hematoma, the RBCs break, the platelets break, there is PDGF release. That causes invites the chemotactic agents. So then you get the neovascularization, you get the fibroblasts, you get the immature collagen. In the remodeling phase, you get the mature collagen or the scarring. I have discussed this in one of my earlier classes. Hypertrophic scars are believed to be a problem in this inflammatory phase. This phase normally lasts for 2 to 3 days. ये ज़्यादा दिन चलेगा, ज़्यादा inflammatory mediators release होंगे, you get a hypertrophic scar. Usually seen along skin tension. This is correct. Keloids happen in dark-skinned people. It is more common in Negroes. It is seen in dark-skinned people. And yes, hypertrophic scars do improve with time. Keloids don't improve with time. Okay, so keloids will remain as they are, if not become worse. Keloids are because of some problem in the growth factors. And I'm sure you know they occur on the sternum. Most common sites, sternum and earlobes, common sites of keloids. And the treatment, there are many attempted treatments of keloids or hypertrophic scars: pressure garments, intralesional steroid excision, intralesional excision of steroid of hypertrophic scars and keloids. These are all attempted treatments. Keloids are difficult to treat, so they are best left alone. Otherwise, आज के ज़माने में this is a preferred treatment: intralesional excision for large keloids. छोटे मोटे keloids, silicone gel, steroids work. If the keloids are large, this is one of the things you can do. They are attempted things you can do. Okay, so hope you guys enjoyed this class. Please like the video. I will see you again tomorrow, same time, 6:30 p.m. where we do some more super specialty topics. Okay, same time tomorrow. I'll share the link on the group. I do have a keloid. If it's not bothering, don't do anything. Okay, they are difficult to treat. If you wish to learn everything in surgery from me comprehensively, all the topics for NEET PG, please follow me. You can take a plus subscription. Remember to use my referral code, that is 10 surgery. This will get you a 10% discount. Okay, and please follow me on Telegram. This is my Telegram link, Telegram group, where I will update you about my upcoming classes and share the links. Okay, so hope you guys enjoyed this class. Do remember to like this video. I'll see you guys again tomorrow at same time. We do some more super specialty topics tomorrow. What topic I'll take, let that be a surprise. Okay, so I'll see you tomorrow guys. Take care, study well, study hard, have fun.